Recording from the Sunshine City, St. Petersburg, Florida, overlooking beautiful Tampa Bay, this is the Sonography Lounge, sponsored by Gulfcoast Ultrasound Institute. This podcast is dedicated to medical professionals and patients around the world interested in diagnostic and interventional ultrasound. Our podcast will discuss everything ultrasound, from news, trends, career paths, new technology, and industry updates. Hosted by Lori Green and Trisha Rio of Gulfcoast Ultrasound Institute, they bring over 4 decades of experience in the ultrasound profession and are here to guide you through this journey. Now sit back, relax, and enjoy.
Hey everyone, and thank you for joining us at the Sonography Lounge, where we discuss all things ultrasound. I'm Lori Green, and I'm here with our co-host, Trisha Rio.
Hey everybody.
We're so happy to have you with us because we just wrapped up day 4 of our Intro and Advanced Interventional and Regen Med MSK course at our facility right here in downtown St. Pete, Florida. And we are excited to sit down with several of our expert faculty to chat about regenerative medicine while enjoying a little happy hour with some cold beverages.
That's right. Yeah, a happy hour chat with some of our favorite people. For those who are unfamiliar, regenerative medicine is focused on developing and applying treatments that support the body in repairing, regenerating, and restoring itself to a state of well-being. Regenerative medicine is a rapidly evolving field for MSK, even though it's been around since the 1930s with prolotherapy, followed by platelet rich plasma, or PRP, in the mid-2000s, and more recently, bone marrow and lipoaspirate applications. Regenerative medicine therapies begin with the physician making an appropriate diagnosis of the MSK condition through clinical exam and imaging, and use that info to determine which regenerative therapy would be the best treatment option.
That's right, Trisha. So joining us in our podcast studio today is Dr. John Broussard, board certified in family medicine and sports medicine, and co-owner of Alliance Regen and Rehab right here in St. Pete, Florida. We also have Dr. Imran Siddiqui, partner and director of clinical operations at Regenerative Orthopedics and Sports Medicine in Washington, D.C., and also Dr. David Wang, founding partner and director of education and training of Regenerative Orthopedics and Sports Medicine in the Metro D.C. area. So welcome, gentlemen.
Thank you for having us.
Thanks for having us.
Thank you.
We're so happy to have you here. So without further ado, let's start things off with a discussion about prolotherapy. What is it, how it helps your patients, etc.
All right. Yeah, so thank you for that great introduction, and it was a nice kind of summary about regenerative medicine there. And so, the recent technologies, the advancements are just phenomenal. It's like every other month, there's a new technology that seems to be coming out, and new research that's really showing, for the most part, that these regenerative therapies work quite well. And so it's easy to get wrapped up in, the newest tech and what's the newest intraosseous application of PRP and what's the, newest method for bone marrow extraction, things like that, which I think are all revolutionizing the field of regenerative medicine. But it's also not bad to kind of look back historically and see, okay, well, how did all this regenerative medicine start? And when you're talking about prolotherapy, which is short for proliferative therapy, which is a term that was coined, I think, back in the 1950s by Dr. George Hackett, we realized that, okay, well, prolotherapy has been around since about 1937, when the first published article in The Lancet, I believe, by Dr. Earl Gedney portrayed using a proliferative solution for the sacroiliac ligaments in terms of improving stability in the SI region. So this stuff's been around for, more than 85 years, and prolotherapy is still a very decent, relevant, easy, minimally invasive technique that can be used, and a lot of it is also not just what's in the syringe, but the actual technique of diagnosis and treatment. And that technique of diagnosis and treatment can be applied to not just regenerative treatments, but frankly, musculoskeletal diagnosis and treatment, across the board. So it's an important foundational aspect of regenerative medicine, I think. Not to mention for your less severe cases of tendinosis, small-grade partial tears, ligamentous injuries, and some low-grade arthritis conditions. It can be very helpful and doesn't require drawing blood or obtaining harvesting fat or bone marrow and that sort of thing. So it's less invasive, and it has its role. So.
Yeah.
I agree, Dr. Wang. Is a good synopsis of prolotherapy and where we've come from, right, as far as regenerative medicine. I think prolotherapy, like you mentioned, it's a technique, not just what's in the syringe. It's not just sugar. So prolotherapy is not a a product, but a whole system of thinking about restoring tissue, joint function, stability. So, prolotherapy is a good learning tool, a good launch pad, and like you guys do, like I do, like a lot of us do, is we use prolotherapy techniques and carry that over with our other regenerative treatments. So whether we're using PRP or anything else, we're using the prolotherapy system. Like you said, it's not what's in your syringe, it's how are you using it.
Absolutely.
And so that whole technique about not just controlling pain, but providing stability and support for that structure is super important. And like you said, it's very cost effective for the provider, for the patient. Learning and doing it in third world countries, it's super easy. And the nice thing about prolotherapy is when you run out, and guess what? You just make more.
Yeah.
Right? So
it's like Doritos.
So for PRP, you get what you get. You got a blood draw, you get your PRP, and that's it. You have to really plan ahead for these treatments. And then, bone marrow, same thing. You get what you get. And so with prolotherapy, you finish your treatment and your tray's empty. You're like, I want to hit this. Well, you just reach over and grab some more, and it's great. So far as you know what you're doing with your needle, prolotherapy is very forgiving. It works very well in everything, really. Spine, I like to use prolotherapy when I'm seeing a patient for the first few times and they have a lot of stuff going on. So I tell the patients, okay, let's pull some weeds. Let's get this, let's get the smoke and the clouds out of the way.
Right.
Let's treat all your stuff super comprehensively. Yeah, you got some bad facets and you got some stuff that we can do some PRP on, but let's do some prolo, shore everything up. Once there's stuff left, then we can come in with our big biologics that, if you need it, right? I mean, that's how I kind of use it. I don't know, Dr. Siddiqui?
Yeah, no, prolotherapy is it's a great place to start for both physicians who are learning and also patients. It's been around for a long time, and despite these great newer treatments like PRP and bone marrow aspirate and MFAT, prolotherapy works on a lot of people and for a lot of conditions. And so, despite it being kind of the OG and the older treatment, we still use it a lot. And, like you said, Dr. Broussard, for patients with a lot of things going on, especially hypermobile patients, it's my go-to for hypermobile patients to start with, because you need a lot of volume in those patients, because not only do you need to treat the injured ligament or tendon, but you probably got to treat all the other ligaments and tendons in the area, because everything's loose, and they're not going to get fully better unless you tighten up that area. So it's a great treatment, great for comprehensive cervical neck treatments, great for comprehensive low back treatments, because you need a lot of volume, you need to hit a lot of structures. So great from the patient care, and also for providers who are getting into this, it's very important that they learn prolotherapy. A lot of them, they're kind of skipping over it, and they're going straight to learning the PRP and learning.
Well, PRP's sexy.
It's sexy.
It is.
Stem cells are sexy, right?
Yeah.
Right.
It's trendy.
Yeah. No one wants the 90-year-old prolotherapy, right?
Yeah.
So it's but it serves as a great basis and great foundation for learning, because you use those techniques doing PRP and doing bone marrow and doing adipose. If you don't have the good skills and the good basis from prolotherapy, you're not going to be as good with those other things.
Totally. And to expand on that a little bit, by the way, I love how you're referring to prolotherapy as the OG, so a regenerative treatment. Instead of original gangster, I think we can call it like orthobiologic glucose, right? How about that? In terms of this comprehensive approach, just to comment a little bit on tensegrity, this is a concept that a lot of experienced regenerative medicine docs will talk about. So tensegrity, being basically tension or tensile integrity, is an interesting concept where a lot of biological systems, the integrity of the system is based on their ability to basically resist tension as opposed to compression. And so a common, analogy for this is that a building with, brick and mortar and all that is designed to resist compressive forces of gravity, right? Which is fine for a building because the building doesn't move, right? But if you have something that's a dynamic structure that has to move and there's different angles and you got to deal with gravity and you have to deal with centripetal forces, this idea of tensegrity where that structure can resist tension from multiple angles is important in the overall stability of that structure. And so a giraffe's neck, for example, is a nice example of a tensegrity structure compared to a building. And so many biological structures from the cellular level all the way up to us, as, in this case, as us as human beings, are tensegrity structures. So the advantage is that you can take something very lightweight that has these tensile, in terms of biological systems like ligaments, tendons, fascia, these different soft tissues that are very pliable and flexible and lightweight that can resist a lot of force. But the disadvantage is that if you have a compromise or injury to a part of that system, it can affect the integrity of that entire system. And so this is why in basic prolotherapy concepts, you want to treat the entire system, that entire tensegrity system. So you kind of have to fix up everything to maintain integrity of that entire structure, which is why comprehensive prolotherapy is designed to treat, multiple structures. Sometimes we're talking, 20 or 30 structures in one sitting. Now I find that especially with the application of diagnostic ultrasound, it helps you to be much more exact where you're treating. So I find that I don't have to treat as many structures. I can use about 1/3 the amount of solution as I used to and still get very, very good long-term results with that. But the idea of tensegrity, I think, is something that's easily missed because you can end up kind of getting tunnel visioned with where you want to apply your treatments. Right. But I don't know how you folks feel about that.
100%, spot on. One of the common questions that I get from patients when we talk about prolotherapy is they ask about their blood sugar. Was my blood sugar going to increase? Mm-hmm. And maybe they're diabetic or maybe they're just conscious of their blood sugar. And what I tell them, and I can tell this confidently, is it's not going to move. And the reason I know that is because I've had a number of patients on pumps and monitors, and they've watched their blood sugars, and it hasn't changed.
Mm-hmm. Same.
So if anyone's out there listening to this and you're considering prolotherapy, but you're scared of the dextrose or the sugar, you don't have to worry about it. It's not going to mess up your sugar. You're not going to have to adjust your insulin or anything like that.
And I'll tell you this, the cortisone injection that the other orthopedist is offering, that's going to raise your blood sugars a lot.
Yeah, 200 to 300 plus. Yeah, I've seen patients in the
really
low 400s
point, you guys.
from
Really good point
cortisone.
For our non-physician listeners.
Yeah. Mm-hmm.
Well, that was... Yeah. I love listening to you guys talk about this stuff. It's just so fascinating. And you're
I know.
So
I've been looking forward to this podcast for so long since you told me about it.
So much fun.
To be in the same room with these guys, I mean, like,
just
this is what we used to do on a daily basis.
I know.
Yeah,
So
y'all work
Three
together.
Musketeers. Yeah.
Stooges, Musketeers.
yeah, I'm just honored to be in the same room with you guys. So
Yeah.
Thanks, man.
So before we move on to PRP, as far as your patients go, do you oftentimes, is this a regular situation where maybe they have certain conditions and you say, well, we're going to start with prolotherapy and this is going to get us from point A to point B, and then it's going to segue into utilizing PRP or some other stem cells or whatever, or is it usually that you're just pretty much, depending upon the condition that they have, you've made the decision that's what you're going to do, see how the patient does, and then later down the road that you decide? Or is that something that you do like a treatment plan with the patient?
Mm-hmm. Yeah, I can start with that. It is injury dependent. Mm-hmm. The severity of injury, that will be the thing that most significantly steers which biologic or regenerative treatment I'm going to be offering. But a lot of times people are in the middle. Mm-hmm. You could treat it with prolotherapy or PRP or bone marrow or whatever. And so in those situations, I have the conversation with the patient. These are the two options. You'll likely need, 3 to 5 treatments of prolotherapy or 1 to 2 treatments of PRP, and give them the pros and cons of everything and let them decide what they want to do. But as I touched on, my hypermobile patients who have a lot going on and their joints are really loose and everything like that, definitely steer towards prolotherapy to start. Like Dr. Broussard said, clean everything up, get everything functioning normally. And then if there's an injury here that hasn't healed or there that hasn't healed, then you can do PRP afterwards to kind of finish it off.
Great.
Yeah, I agree. I approach it the same way.
Great.
Especially with those hypermobile patients. We can get academic about it. We can look at the research and we can say, oh, PRP is stronger, it works better. Well, not everybody wants to have their blood drawn. Not everybody can financially do PRP or one of these big things. So you have to look at your patient and see who's in front of you and make this decision with them. And for a hypermobile patient, that's a patient for life. Like, we're not fixing your hypermobility, we're managing it and we're making you more functional. So yeah, PRP may be more potent, but you need the volume and you need the frequency of the treatments. And so prolotherapy, I think it works fantastic for that population.
Great.
And like, let's say you got really bad arthritis and we're talking about fat or MFAT or bone marrow and we need to put something in there. I'm still doing prolotherapy. We still got to address everything outside of the joint, the ligaments, the fascia, the tendons, the stuff that Dr. Wayne was talking about. So we're still incorporating some prolotherapy into the treatment plan. So it's kind of always there.
Yeah.
And for our listeners out here, hypermobility, another term that you may hear is Ehlers-Danlos syndrome. Hypermobility is becoming a more commonly diagnosed condition. A lot of people with fibromyalgia, we're seeing it's actually hypermobility. And basically what hypermobility is when your tissues are just naturally more elastic than the norm. And Ehlers-Danlos is a subset of hypermobility. And as it's becoming more popular, a lot of providers are calling all hypermobility Ehlers-Danlos, so it can get confusing. So if you hear hypermobility and Ehlers-Danlos for now, until we sort this thing out, they're pretty much the same.
It's a continuum.
Yeah, there are, was it 6 subtypes or something like that of Ehlers-Danlos? I think type 3 is the hypermobility only subset where you don't have effects on the heart, because there are other aspects of Ehlers-Danlos that can affect your cardiac or heart function, that sort of thing. There are methods of genetic testing, and it gets pretty sophisticated, and that's not something that I'm not intimately familiar with. But I think the idea in terms of having these patients for life, the idea is that the connective tissue, so the collagen fibers that make up that connective tissue, are, as Dr. Siddiqui was saying, they're more elastic, and it is almost like on a cellular level, something that is for that individual, it affects all of their collagen tissues, and so you can temporarily fix them with things like regenerative therapies and really get those elastic structures to become more solid, more stable. But because of that cell turnover and that collagen, just from that biological basis, eventually those collagen fibers will become more elastic again, and then their symptoms can return. So unfortunately, you do have to treat them kind of longitudinally. But a lot of times I find that with the regenerative treatments, they'll be good for 6 to 12 months if, in some cases. And it can affect multiple joints, and so sometimes some joints are more heavily affected than others. But the regenerative therapies are one of the few things that can really get these folks lasting benefit, even though you do have to do them, longitudinally. It really improves their quality of life quite a bit.
Wow.
And I'm just thinking of a patient who I had with very bad hypermobility. And this is when I was with you guys. This girl literally could not walk through water, even a few inches of water, without her toes dislocating.
Oh, wow.
It was that bad.
Wow.
So we treated her with prolotherapy. Cost-effective, dextrose-based prolotherapy, and her toes are fine. So, there's a, with all these sexy regenerative treatments out there, these stem cell clinics popping up, especially here in Florida.
Yeah.
They're outnumbering Starbucks by now.
That same sentence.
I mean, you
True.
don't need crazy expensive multi-$1,000 treatments. All you need is someone who knows what they're treating and how to manipulate a needle and functionally to help your tissues. And you can do that with sugar, dextrose.
100% right. A dextrose treatment by a skilled provider done to, a comprehensive treatment to the knee joint. So you do the ligaments, you do the capsule, you do the tendons, you do the joint. That is 10 times more valuable than a $10,000 stem cell treatment where they just put it in the knee.
Yep.
Exactly.
Just put it in the knee joint. And that's what you see is going on with
100%.
all these stem cell clinics, is they're going in, they don't know what they're doing. They're creating these stem cells properly because they have the guidance of industry, but then they're just dumping it in the joint and saying, we treated your knee, and yeah, maybe 40% will get better, maybe half, but for how long? And they're not fixing the functional problems, and they're not fixing the ligaments and supporting structures. And so that it's going to catch up, and these it's not sustainable for people to be paying that kind of money for these
Absolutely.
treatments.
Right. Yeah. It's a difference between the profitability and the managing patients' care.
Correct.
And giving them the best outcome.
Absolutely.
So, Dr. Wang, I have a question for you. You're well equipped. So there's
I was going to comment on that further, but
oh, please do. So there's a misconception out there, probably from old school providers passed down to patients, and it scares some patients that they don't want prolotherapy because it causes scar tissue.
Yep.
Can you speak to that?
Right. So, sure.
How that came about and what's actually really going on.
Yep. So as we mentioned before, so prolotherapy, or the concept of the technique of prolotherapy, was first introduced around 1937. But the term prolotherapy was not coined until the mid-1950s by Dr. Hackett. Between 1937 and 1950s, it was called sclerotherapy, right? Because back then it was felt that you're injecting these irritating solutions, and dextrose was, I think, not really on the radar at that time. They were using more caustic solutions and such, and they were thinking that it was causing like scar tissue buildup. And one of the reasons for that is because originally sclerotherapy was being used for treating inguinal hernias, and they actually were encouraging scar tissue development in order to scar that area down to be able to keep that hernia from actually protruding through, right? But the problem is that they were taking that concept and applying it to a prolotherapy treatment of like ligaments and tendons and all that. And there were histologic studies done in the 1950s that showed that that was not the case, that it was actually creating the repair of healthy tissue. This was done in rabbit tendons, I believe it was. And then this was followed up by multiple studies through the 70s. And then when ultrasound was being used for diagnostic purposes, then there were more recent studies, like Brad Fullerton's study from 2008, for example, is a very key study, where you could demonstrate the return of normal organized collagen fibers and body tissues after dextrose prolotherapy that had nothing to do with scar development, right? So I think that, unfortunately, that idea of scar tissue development was kind of an erroneous thing from the 1940s that had been basically debunked, as it has been debunked for many decades now.
Cool. See, I told you.
I'm well equipped.
He's well equipped. He's just, where do you keep all of that?
Oh, goodness. Something though that I would like to mention. So, being the old guy in the room here, it's so interesting how things will come full circle with this. So when I started my practice, and we were the second academic institution to do PRP, this is back in 2006, I think, when I was in my residency up at Harvard Spalding, where Dr. Siddiqui also trained. And I used to do more PRP back then because it was, we had good access to it. It was very effective. And then as I developed my skills, both in diagnostic, especially in diagnostic ultrasound, but also just in basic clinical acumen, I found that I could get the same types of folks better with just a couple of prolotherapy treatments. So as my skills improved, I was doing less PRP and more prolotherapy. But then after, I don't know, another decade, it's starting to come around the other way, where I'm realizing that PRP in many cases ultimately is actually a more cost-effective approach. It is more expensive, it's higher technology, however, it's a good 3 times more powerful than prolotherapy. So I'm finding with some of these conditions in my more chronic, my patients with chronic musculoskeletal issues, that just doing the prolotherapy repetitively, it doesn't quite get them over that critical mass of healing. But if I apply just 1 or 2 PRP treatments, it's like that seems to be like the magic thing, and they seem to do a lot better. So even my patients that have these chronic conditions, multiple body areas, they've done well with prolotherapy, but it's like they're always somewhat symptomatic. I treat them with PRP, and then now they're like, you know what, Dr. Wang, I really like the prolotherapy, but the PRP is just a lot better. And they need fewer treatments, and overall cost is actually lower because they don't need as many treatments. So it's an interesting balance to strike, right?
Yes.
Between the lower cost prolotherapy, but you need more treatments, versus maybe just 1 or 2 PRP treatments, fewer visits, less time off of work for them, right? So there's this give and take with
Yeah, and that's where the relationship with the patient comes in.
Right.
And it's relational and not transactional.
Correct.
And you figure out,
Yep.
what do you need from me right now, and what are your goals, and what can we do to get there? If somebody's traveling 2 hours to come see us, I'm not doing prolotherapy, right? We're doing PRP. I'm
Right.
not going to make you come 2 hours every month for the next 6 months.
Right.
We're going to do PRP and hammer this thing.
Yeah.
But if someone lives down the street and they want to do prolo, yeah.
Yeah.
And often, to your point, Dr. Wang, is those patients who are getting the prolotherapy, they're getting better. There's often, a couple spots that just
Totally.
aren't responding as
Yep.
well. They're just more significantly injured, and
Absolutely.
and then that's what's driving the maladaptive biomechanics. That's putting more stress on everything else, and why they keep on having to do repetitive prolotherapy. And then if you treat those specific spots, you can do everything with the PRP, but making sure you treat those specific spots with the PRP, they turn the corner, and then everything else falls in place.
Okay.
So,
Well, you guys have kind of segued for
You're right,
us,
perfectly.
which is great. So we're talking about PRP. So for maybe our listeners who don't know what that is, can you kind of elaborate on what that is, what it's used for, why it's indicated in certain situations, and what is the importance of ultrasound guidance?
Right.
I'll take it.
yeah, go for it.
So PRP, platelet rich plasma. So in our plasma, in our blood, we have multiple components: red blood cells, white blood cells, platelets. Platelets, along with some other compounds and proteins, are what rush to the surface of your skin when you cut yourself, form a scab, allow the tissue to heal underneath. So we take those platelets that are rich in various growth factors, and we concentrate those platelets, and we inject that into damaged tissue that facilitate healing. So we are in the United States, where we have pretty much anything we want, whenever we want. One of those things being anti-inflammatories. Hurt yourself, sprain your ankle. What do? Pop a bunch of Advil. What does that do? That stops the inflammatory process of all of these good nutrients rushing to the area to repair tissue. We need inflammation. We need to go through the process of all the inflammatory phases to allow tissue repair. So the nice thing about Prolo, PRP, whatever, we're taking your body back through that injured phase, reinitiating inflammation, giving your body the constituents it needs with the growth factors to support the healing phase. Ultrasound guidance has, it has totally transformed my practice. I learned how to do prolotherapy, palpation guided, through the Hackett-Himwall Foundation with Dr. Wang as my fearless leader. And I got pretty good at it, palpation based. And then with the addition of ultrasound, I actually got to see a lot. I got to see what I'm injecting. It also put a little healthy fear in me, because I got to see how close I was to some bad stuff when we were injecting. And
Well, bad in as if you hit it bad,
yes.
right? Yeah.
So not only does it increase your accuracy, so you're safer, but you're also going to help the patient more, because now you can quantify this tissue. And so we can prolo things all day long, palpation based, but if we don't know what we're actually treating, they're not going to get better. Like, oh, doc, we've been doing prolotherapy here for about a year now to the same spot, and I'm not getting better. Should we get an image? And then there's like a huge tear. So maybe prolotherapy might not have been a good option, right? Maybe we need to put something more powerful in there. So ultrasound has helped me in that aspect from the get-go. And I tell patients and other providers that we help teach, even this week, they ask about the ultrasound and do you have them come back? I'm like, no. When I get there in the morning, I turn my ultrasound on, and it's an extension of my physical exam. I want to know exactly what you're dealing with right now so we can come up with a game plan.
100%.
So it's like a vital sign. It's part of our physical exam.
Yeah.
Without that, I'm going blind, and you're not getting better. And so, yeah, accuracy, safety, best outcomes.
Yeah.
Can you do a lot of what we do without ultrasound? Yes. Can you do it to the same level and the same degree of accuracy and same degree of benefit for our patients? Absolutely not. Ultrasound, it's the standard of care. It is in Canada. They're moving towards it. In the next couple of years, you won't be able to do injections without ultrasound.
It's already starting.
And there's a reason for that, because of the accuracy. Studies show that they took orthopedic surgeons with at least 5 years of clinical experience using their traditional palpation-based, quote-unquote, blind injections versus a first or second year resident, I can't remember. This was a study, first and second year residents with 1 month, just 1 month of ultrasound training and they went head-to-head on injection accuracy, injecting with a little bit of dye and then doing a CT scan or X-ray afterwards to see accuracy. And the 1 month trainees with 1 month of ultrasound training completely blew out of the water the orthopedic surgeans with 5+ years of experience.
Wow.
The only thing that came close, I think, was the knee, which was about 90%, about 85-90% accurate with the palpation based. It was 99 with the ultrasound, but like the elbow was like 50-60% with palpation based. And still, everything was above 90% for the ultrasound guidance. So I mean that type of study has been reproduced over and over and over again. So it's the gold standard. Everyone should be doing it. If you're not doing it, you're not treating your patients properly.
So Dr. Siddiqui, if I'm a patient of yours and we're talking about bone marrow or MFAT with some stem cell and other healing factors. And, I trust you, and I'm forking up a lot of cash for this. And you tell me that I can, with about 50 to 80% accuracy, that I'm going to get this in the joint. That's not good enough for me.
It's not good enough for anybody.
80%'s on the high side. For me.
Right.
80%.
If you tell me there's about an 80% chance that your $5,000 is going in your knee.
Right,
I'm not okay with that.
We're going to go through all the rigmarole. We're going to numb up your skin. We're going to numb up your fat. We're going to spend half an hour taking out your fat. We're going to process it. We're going to use the right anesthetic so we don't kill the stem cells. And then we're not going to use ultrasound and pray that it gets in the joint. It's a flawed system, and it's people trying to do things that are sexy, right? That they're just not apt and well trained to do. So they need to come down here to Gulfcoast and get trained up and do it right.
Absolutely.
Come join us.
No shortcuts.
Right. You got to make the commitment. If you're going to do it right, then do it right.
Yeah.
And you're going to have to invest in the right equipment and the training so that you provide the best service to your patients, and they're going to get the best outcomes, and your patients then will come back to you. But isn't it nice to be able to see the anatomy, not just where you're looking to do an aspiration or injection, but also the surrounding anatomy. There might be anatomical variations, blood vessels going where they don't normally go,
Nerves.
things like that.
Yeah, it can
That
save.
could be devastating, right?
Not everybody reads the anatomy books.
Yeah. And there's
Patients
variants.
are different.
There's variants.
Exactly.
And I get patients, not uncommonly, and it's becoming more and more frequent. They say, oh, well, they come in with an injury that they've had for 3-4 years, and they say, I've already tried PRP. So the first question I ask is, okay,
It's very common.
who did it? Then I ask, did they use ultrasound guidance? If they say no, then I say, we're not sure if you got PRP. They may have put your PRP somewhere, but I don't know if it went in the injury, and most likely it didn't.
Right.
And then the third thing I ask is do you know what kind of either kit or everything that they use? Because there's a wide range of quality of PRP, and that's even among these popular brands. And that even bleeds into the research. There are a lot of articles that have been written that are negative to PRP. When you look in the nitty-gritty details, the PRP kits they use actually don't create PRP. They create just whole blood, pretty much like 1 to 2 times X of your normal platelet concentration, which is not PRP. That is normal platelet concentration.
Right.
And so we've seen and over and over again that platelet dose matters, and the higher dose up to a very high threshold, but a certain threshold is more beneficial. And if you don't get to that 6 to 8 times X, you're not getting a good PRP treatment. So when those patients come to me, I say, well, you may have gotten something, but you didn't get PRP where it needed to go. So we often have to do it again.
Absolutely.
That actually ties into making sure from the physician standpoint that if you're going to be offering that service and you need to invest in the equipment, you need to invest in the training, but you also need to invest in the time to learn about these things, because a lot of physicians probably aren't aware of that there are differences between kits and so forth.
Yeah.
So
and unfortunately, the industry and the manufacturers and those who are selling the devices are doing a lot of the education for these individual practices, right? And you're getting skewed information because they're trying to sell you a product. They're invested in getting the patient better, but that's not their primary outcome. Their primary outcome is to sell the product.
Right.
So we have to take that education out of those hands and make sure they're getting it from the leaders in the field.
Right.
Yeah.
And how much training have they had?
right.
I've seen reps who've had 2. They're like, hey, I ask them how they're doing. Yeah, I've been here for 2 months. It's like,
You're like,
Right.
"Oh."
Yeah.
you ask them a technical question. They're like, let me get back to you on that.
That's right.
Yeah.
So one thing that like you said, and that's very common here actually, is we get patients who they've had PRP or they've had stem cells or whatever they want to call it, and it didn't work for them. And same thing, who did it? Because we're at the top of the game. We know people around the country who did it. And if I don't know the guy, I'm looking him up. And what I tell people is, in residency, or they'll ask, well, how long did you have to go to med school to learn this? Like, you don't learn this in med school.
No.
Mm.
You don't learn this in residency.
No.
Like, we touched on it on fellowship, but what they teach you in med school and residency is how to inject cortisone into a joint and a bursa. So you want to get into the PRP world, and it's a little bit more than just switching out what's in your syringe. I can teach a monkey how to find your joint,
Yeah.
but again, it goes back full circle. It's the whole,
Right.
it's the organ system. What are we doing with the stuff that's in our syringe?
Yeah.
It doesn't matter what it is. You got to put it in the right spot.
And also cortisone. Like if you're using cortisone, you can be sloppy with it. Cortisone has a very regional effect, right? You can inject it near the structure, kind of near the structure, some in, some out. You can inject it. Heck, you can inject it in a muscle.
You can inject it in your glute muscle, and your migraine goes away.
Exactly.
Yep,
So
that's right.
So cortisone's
Your
really
back feels
powerful.
better for a week.
It's true.
Yeah.
For better, for worse, it's really powerful. You can put it anywhere, and it's going to help. So that's why a lot of people who've been working with cortisone, they don't have to be precise with their injections because it still works.
Yeah.
But for our stuff, if you want it to work and you want it to work well and you want your patients to have good outcomes, it has to be extremely precise. What'd you say, Dave, in your lecture today? 0.02 millimeter, 0.2 millimeter?
Approximately, 0.2 millimeter accuracy with
0.2
ultrasound.
with
Yep,
ultrasound.
right.
Yeah.
Yep.
And you need that. You need that
you need
accuracy.
it.
The stuff we can see on ultrasound,
Oh, it's amazing, right?
people bring their MRIs in. Well, my shoulder hurts or whatever body part. My X-ray was negative. My MRI was negative. What are you going to find with that thing? Well, let's see.
Yep.
Why didn't my doctor do that? I don't know. Go ask him.
Right.
Right? So, or her.
So to comment a couple of comments. So I love this very important fact that cortisone has this kind of regional effect or even systemic effect. Now, granted, if you do a cortisone injection in the gluteals and it helps with migraines, is it even more effective if the person has their head up their rear? And I wonder if there's like a scale there in terms of effectiveness, but we won't go into that.
That's so asinine of you.
Well, I just, I like to be the butt of my own joke. Two things that I'd like to bring up. One being the paradigm shift with regenerative medicine, and then the second being the paradigm shift with ultrasound, diagnostic ultrasound. Very fascinating. So when I went through my training, so Harvard trained, conventional, traditional, very good musculoskeletal training, and you learn your basics. I learned a little bit of regenerative medicine at the time because Dr. Joanne Borgstein, who was heading up the outpatient MSK program, was really getting into some of the ultrasound, diagnostic ultrasound and PRP. So she's been a fantastic mentor. But we were one of the few facilities to do that. And when people talk about regenerative medicine, unfortunately, as we had touched on before, many times they will take regenerative medicine products and solutions and sort of stick that into the paradigm of traditional orthopedics, right? So they're taking that square peg, trying to put it in the round hole, and they're just taking that PRP and they're just sticking it in the joint, where they're taking that, BMAC and just sticking into the joint, and they're not thinking at all about tensegrity, they're not thinking at all about the comprehensive nature of musculoskeletal structures. And so the training in regenerative medicine, I think, was very helpful to expand, our horizons with regards to, what's this iliolumbar ligament? Oh, you can get sprains on that? Oh, hey, you can treat that with regenerative medicine. It can help their back pain? Wonderful. Then on top of that, you bring on diagnostic ultrasound, and again, big paradigm shift. So here I am thinking I knew some stuff, right? Because I had very good quality prolotherapy training. I probably learned how to inject 200-something structures, right, in my training. I thought I knew some stuff. Well, then I started doing diagnostic ultrasound. I hated that machine for like the first 2 years because it slows you down. We had that old green beast, that old BK,
wow.
the machine's like this big and then the screen's like this, right? And it's very grainy. You don't know what you're looking at. And we struggled with that thing for a couple of years. And it felt like I didn't know what I was doing. But the more I used the ultrasound, the more I realized, number one, it is extraordinarily helpful and effective for targeting the conventional orthopedic type things, right? You see your partial supraspinatus tear, great. You can see it on sub-millimeter accuracy and really get it into that little partial tear.
Yeah.
But even more importantly, there was another paradigm shift where now I'm able to see things and treat things that even with high-level regenerative medicine and prolotherapy training and high-level basic orthopedic conventional training, aside from that, now there's things that I can see, like, for example, these fascial micro tears that are literally 1/4 of a millimeter thick. There's no way to be able to diagnose them otherwise. You can't even diagnose them through palpation. There's no way you're going to see it on MRI, CT scan, they're invisible. But on ultrasound, you can see them. Not only can you see them, but now you can treat them with that accuracy of 0.2 millimeters. Now this opens up, again, an entire new treasure trove of things that you can identify and treat effectively in folks that have tried other treatments, even advanced regenerative medicine treatments, and they didn't quite get fully better. Now we can use the diagnostic ultrasound and really identify those things. Absolutely amazing.
Yeah.
So we all do the same stuff. We're changing the game in orthopedics and sports medicine. And we have a lot of highs in our day, right? There's a couple of lows, but there's a lot of highs. And one of my favorite points, one of my best points in my day is when someone comes in with some vague pain, maybe chronic. They've seen a lot of people. And we find that little spot and we put a needle in it and, that's my spot. That's my pain. You found it. What is it?
Yeah.
That's the best.
You did that for me.
It's
I
like
had that tiny little tear
MRIs
in
are
my
normal.
rotator cuff.
Why didn't anybody else find it?
You proload it.
Because we have high resolution ultrasound
Yep.
with our exam,
Yep.
our knowledge of anatomy. You find that little spot and then you change somebody's world. And you know what's coming next. And then my next best thing is when they come back and say, I can play with my grandkids now. You fix my pain. And
Yeah.
but
Aw.
it's just great.
Because you see where
You can see.
I have a question. You guys hit on briefly cortisone, and I know a lot of people out there, I hear them say, I'm just going to go get a cortisone injection. So why are we introducing different treatments? Like, what is the difference between cortisone and prolotherapy and PRP?
Oh, that's easy. I can take that one.
Yeah.
Can I take that one?
Yes.
All right. So the reason that we're introducing these treatment options is because we don't work for insurance companies.
Right.
And that's the bottom line. So we want what's best for our patients. Traditionally, if you look at diagnose, and we talked about this earlier this week, if you look at diagnosis codes like over decades, you see rises and falls of diagnosis codes and procedures that are being done. Are the diagnoses going away? No. They're just not being reimbursed anymore by the insurance companies. Are the procedures not good enough anymore? These nerve blocks not working? Of course they're working, but the insurance doesn't pay for them anymore. So you start to see diagnoses rise when insurance reimburses well for these diagnoses and these procedures. And that's kind of how medicine works. And you have all these cortisones and hyaluronic acid and surgeries, and that's about it. So we have a bigger toolbox that we operate out of, regardless of who is telling us what to do and what not to do based on reimbursement codes. We work for our patients, not the insurance companies.
And on a granular level, that's absolutely right. I mean, it's a shame that whoever's sitting up there in the
200th
floor of the building is making these decisions, but
The C-suite.
Unfortunately, they are.
Cortisone, eh?
And we're kind of at the mercy, and there's so many layers of bureaucracy, right? It's like, the business that you work for, most often, if it's private health insurance, selects the insurance based on most often cost, right? Because it's damn expensive. And then they aren't really looking at what's covered and what's not, what is. And then the patient just knows that they have this insurance, and they're injured or hurt, and they assume you can do everything you can to fix it under that insurance. And unfortunately, you can't these days. That's becoming the norm in all specialties, more so, not just ours. But also on a granular level, cortisone is a natural hormone in our body that does a lot of different things. But one thing is it's anti-inflammatory. And we give super therapeutic doses when you do a cortisone shot, like 1,000 times the normal body's concentration.
Yep.
And so basically what it does, it's, I think of it as like the napalm. You're just getting rid of every inflammatory molecule, good, bad, ugly, everyone, they're all gone. And so people feel better on cortisone. That's one reason why it's used and why it continues to be used. But as you see in the movies, when people get a cortisone shot and then they continue to play on it, they tear their ACL or whatever. These cortisone shots are just masking pain and masking injuries. They aren't actually fixing anything. So you're masking the pain, and then you're going out continuing to play on it. You're doing more damage to it, and on top of that, more and more research is showing that the cortisone itself has negative effects specifically on cartilage and ligaments and tendons. It kills cells at those super therapeutic 1,000-time dosages. And so on top of that, you're weakening the tissues even more. And so, the traditional orthopedic model for the vast majority of conditions is, you do some physical therapy. If that doesn't work, cortisone shots until everything's damaged enough that you need surgery. And that's for joint replacements, that's for tendon injuries, and that's everything. And so, and it's this cycle over and over again. What we're trying to do is stop that. Let's prevent the surgery. Let's prevent needing to take a year off to recover from this. Let's fix the ligaments, the tendons. Let's fix your biomechanics. Go see a good physical therapist, and let's rehabilitate the entire body.
Yeah.
The irony of that is that more and more research is showing that application and exposure to cortisone accelerates degeneration of both cartilage and joint as well as soft tissue. So you've got these practitioners that are doing these cortisone injections, and they say, okay, well, keep doing this until you need the joint replacement. But it's actually accelerating the timeline to get the joint replacement because you're causing that additional degeneration.
Put you in the express lane.
Yeah, right, exactly.
Exactly.
And one way that I like to put it is that the reason that cortisone can work well for pain and inflammation is that it reduces cell metabolism, right? So by reducing cell metabolism, it reduces the release of those inflammatory mediators, so it does reduce pain. But when you reduce cell metabolism, you also reduce the cell's ability to maintain the structure that it's responsible for. So if it's a cartilage cell, then the cartilage degenerates. If it's a tendon cell, then the tendon degenerates. And so those tissues will degenerate faster. And regenerative therapies are actually the opposite of that, right? We're actually promoting metabolism. We're increasing that cell metabolism so that you can get that release of the necessary growth factors to repair the collagen and other damaged structures. So in essence, we're doing the opposite of what cortisone does in order to repair these tissues.
On that note, regenerative and versus degenerative medicine. How about these patients who they listen to their physician because they trust them, as they should. But as many physicians as a whole, we've done a disservice to our patients. But these patients maybe have migraines, typically migraines. Let's go with migraines. And their doctor is doing Botox to treat their migraines or other, physical ailments. For me, that's degenerative medicine. Yes, you're controlling, you're masking the problem, but how about if we, instead of paralyzing the muscle, we fix the enthesis of the muscle, which is where the tendon attaches to the bone, and we heal that tissue, and then the muscle stops screaming. And then we don't need degenerative medicine, cortisone, Botox, etc. I don't know. Thoughts about that?
No, absolutely. And yeah, I do use Botox in my practice, but it
has its place.
It's a last line.
Yeah, it has its place.
It's if we've tried to fix everything else, and we can't for whatever reason get this muscle to turn off, and it's whatever if they have a neurologic disorder. It's usually a neurologic disorder that causes it. But I agree. We see too often that practitioners are jumping to Botox for migraines or muscle spasm anywhere, when a lot of the time that's the downstream effect of a primary injury somewhere else. And you have to do your due diligence and look for that primary injury because, Botox, for insurance companies too, Botox is expensive and you need it every 3 months.
Yep.
And it's also not healthy for the muscles. If you look at muscles that have had Botox over a long period of time, they're fibrotic, it's full of scar tissue, they're thin, they're weak. Once they're in that situation, they can never rehabilitate back to their norm. They're on Botox for the rest of their life. Yep. So while I use it, like I said, I use it sparingly and only as a last resort when we've exhausted everything else.
Yep, I agree. And with those muscles looking like trash with Botox, how about people with spine pain who just love their RFAs? Let's just burn the nerve to cut the signal to your pain. What happens in those situations?
Well, so what Dr. Broussard, for those who are listening, is talking about is for people who are having pain in their spine that's localized to the joints in the back of the spine, there are these nerves that provide sensation to that and only sensation to those areas. And so if you're having pain in that area, they're the primary nerve causing that's relaying that pain signal to your brain. And so what the traditional pain management treatment is you go in and you burn that nerve. And it seems like a decent idea on the surface.
Pain's gone.
Pain's gone. And it's gone for 2 or 3 years, but the nerve will grow back and you got to do it again. But every time you go in and burn that nerve, you're creating more and more scar tissue. And at the same time, it's been shown that it causes that these nerves may not be all sensory. There may be some motor function to them, and that you get atrophy of the paraspinal muscles, which are the exact muscles that you're trying to rehabilitate in physical therapy for back pain, which has been shown to be beneficial.
Yep.
So you're decreasing the pain. It's kind of like a cortisone shot 2.0, right? You're mortgaging your future to get a pain benefit right now.
Dr. Siddiqui, are you telling me that RFA could be also an express lane treatment option to back surgery?
Oh, absolutely.
So who wants that?
Everyone who performs back surgery.
There it is.
So we talked a lot about pros and cons of these treatments and who's doing them, who's not doing them, who should be doing them, who should not be doing them. What kind of questions can we ask potential doctors who are doing these treatments to vet them, Dr. Wang? What can I ask you if I'm interested in prolotherapy, PRP,
As a patient.
and I'm calling your office? What kind of questions should I be asking?
I think that the devil's in the details, right? I mean, we spent some time during this podcast talking about the importance of quality of training, making sure that the practitioner truly has an understanding of what's going on. I think that's one of the difficulties about regenerative medicine is that it's a little bit like the wild, wild west. There isn't sufficient oversight, really, in these technologies. The technologies, some of them are very great technologies that are going to help a lot of people, but it's a very low barrier to entry, right? A product representative just basically has to show up at the practitioner's door and say, hey, we got a package deal today. If you get, 6 packs of this particular orthobiologic, then, we'll give you the 7th one free or whatever. And they send you these little tubes of growth factors. Next thing you know, you're doing stem cell treatments, which really aren't stem cell treatments. So it's a very low barrier to entry. There's no, qualifications per se that you have to have. And the marketing is very intensive for these types of practices, as you know, right? And so I think the number one thing is to understand what is the experience level of the practitioner and how do they kind of go about doing what they do. Like, for example, an important thing is, are there patients that they will consider as not being good candidates for regenerative medicine? And how do they figure that out? If everybody's a regenerative medicine candidate, then they're not necessarily doing their due diligence for proper diagnostics. And so I do tell people, like, one important consideration is, patients will ask potential docs, okay, well, how many of this procedure have you done, right? If you're getting a surgery, well, how many of those gallbladder extractions have you done, right? How many of these, in this case, PRP treatments have you done? How many stem cell treatments, and so on? And people have the tendency to think that docs that perform the most procedures are the most experienced and therefore are the best docs to see. But that's not necessarily the case, right? I would prefer to see the doc that hasn't done 20,000 PRPs. I'd rather see the doc that's done maybe 5,000 PRPs. They've done plenty of PRPs to be experienced, but they're not doing PRP on every single person that walks through the door, right? And I've seen this happen where docs that have done something like 20,000 PRPs, they PRP everybody, they get a lot of failures, and those failures, unfortunately, they come to our office, right? And then you see the lack of diagnostic thinking, that they go through. So you have to ask the right questions to make sure that that doc is thinking critically about your case and that they really care about you and care about getting you better for hopefully in the most cost-effective way, right?
Yeah, that's good.
Yeah.
I got to say, like, right off the bat, like, so from a patient perspective, I've seen, as far as red flags, you got to watch out for. Luncheons, I've been to one before where, I was actually looking for instructors. We went around and we went to a luncheon and they basically promised the world to a room of elderly folk. And they said, blah, 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 this is what we're going to do. And then they had a number of people come in and basically prove that they could walk again and say, oh my God, after 2 weeks, I was going up flights of stairs and I had been immobile for years.
Right.
And
Yeah.
it was going to be about $10,000. You would put up front at this luncheon, you would put your down payment. And I was like, this is not right. And I was talking to the directors and I was like, do you guys use ultrasound guidance, asking questions? No, they didn't. And they were using some questionable products. And that was a pretty scary thing. Then there was another time where I have friends that have gone to facilities and they went for one evaluation and they were told, right off the bat, you need 12 treatments.
Wow.
At $1 amount. I was like, you need for PRP. And I was like, this is...
It's for PRP.
I would call that the dirty dozen.
You remember
right there.
Kim? What did they say to Kim?
I've seen that.
Got to do
patient.
X amount of...
I'm pretty sure we got her
Crazy.
very happy in 3 or less treatments.
3 or less
I think it was
treatments.
one she was feeling a difference.
Yeah.
So-
Or they'll say, well, we're going to try the PRP or prolotherapy. It's a 50-50 chance you'll be okay.
That doesn't work,
well.
surgery.
And
Yeah.
if that doesn't work, at least we tried
Yeah.
the non-invasive, and then we'll have to do surgery. Do they use ultrasound guidance? Nah.
So one of the
They want it not to work. That's
Yeah,
part of their business
exactly.
model.
Yeah,
There are
they want it not to
folks.
work. Yeah.
Right.
There are folks in our area too. I'll show you it doesn't work. You know, pay me $1,000.
Right.
I'll prove it.
We'll prove it. It
I'm doing
doesn't work.
surgery on you anyway.
You're
You
gonna-
might as well get
you're
some
gonna need
cash
surgery.
front end.
Give me some money to prove
It's sad.
No,
I mean, there's always going to be, that situation out there. We have plenty of orthopedic and sports medicine physicians that are here at our class, and they're doing it the right way.
Yeah,
And they've
yeah.
invested the time, and they're purchasing the equipment, investing the time, and they want to do it right. But I think this is definitely a good discussion, because most people of the patients, they aren't aware of
They're not.
even
They're not.
the different types of treatment options that are available. They don't really understand the value of utilizing ultrasound guidance, and they don't know the questions to ask.
Right.
And they're just going to their orthopedic or whoever, their primary care may have referred them to someone, and they're just going in with the trust. You're a doctor, and whatever you say is the gospel truth, and I'm just going to do what you tell me what to do, and,
Yep.
Right.
and so it's on the patient too
Yeah.
to be informed.
Ask
And
questions.
there's
Ask questions. Do your homework.
Do your
If
homework.
your doctor or
Right.
whoever you're seeing, it should be a doctor, but whoever you're seeing, if they don't do a proper physical exam
Right.
and hear your story, do an exam, and do some imaging, you should leave. I hear your story. I already know what's going on.
Yeah.
I do a physical exam to support that
Yeah.
theory. I do diagnostic ultrasound to support that theory. We'll do diagnostic injections to support that. After all of that, we're golden. We know what we're doing.
Right.
And if your doctor doesn't do that, go somewhere else.
And a big issue on the patient side too is the insurance model. Like it
Yeah.
takes
Yes.
now 3 months to a year to get in to see somebody. You've
Yeah.
already invested that time, and now you are like, oh, I can't. I don't want to waste more time going to find another doctor.
Yeah.
to get
That's
a
true.
second
That is
opinion.
true.
So,
Right.
Yeah.
we run into that all the time,
Oh, yeah.
and personally, and
Or you just stop looking because you don't trust
or you
anyone
stop looking.
anymore.
Yeah.
Yeah.
You just waited
You've been
immediately.
burned.
And also the types of, even if they are using ultrasound, what type of system are they using? Not
Yeah.
all systems
Yeah,
are the same.
that's true.
There's a lot that get into it for the first time, and they might go by cost of that system to get, but then they're not going to have the resolution to be able to actually
true.
diagnose certain things.
Right.
Yep. Yeah, there are three questions for all you patients out here, and everyone could be a patient at some point. So for anyone
Right.
interested in this stuff, 3 questions you should ask your
I'm
provider.
very patient.
You are very patient. There are three questions you need to ask. One is what kit or are you using, and if they can't answer that, go somewhere else. And if they do answer it, research it yourself to see what exactly you're getting. Number 2 is, are you using image guidance? And ultrasound is best, but fluoroscopy can be used as another image guidance for a lot of joint injections. It's not as good for soft tissue. And then 3, probably the most important, is what structures are you treating? So where are you putting the injections? And if they just say, oh, we're putting in the joint, it's going to leak into where it needs to go, or it's
It
going to
knows
go
where to
it's
go.
gonna go.
It knows where to go.
No, that's when you walk out the door.
It's your body's
And
AI.
if you hopefully you have an MRI, and at the end of the MRI, it will summarize the multiple different injuries that you have. If they aren't listing those injuries as all the areas they're going to treat, it's not going to be a good treatment.
Not gonna work.
So I think
That's good advice.
Yeah, that's
Yep.
really good advice.
So AI doesn't mean artificial intelligence. In that case, it means adversely performed injection.
Exactly.
And another interesting piece to bring up is that a lot of times, patients will see us, right? They'll get our opinion, and then they'll either go back to their orthopedic doctor or seek a second opinion with an orthopedic physician or orthopedic surgeon, which is perfectly fine. But you have to also ask the orthopedic surgeon the right questions. And many times our patients will say, well, Dr. Wang or, Dr. So-and-so suggested regenerative treatments, and, he feels that either prolotherapy or PRP works. What do you think of that, Dr. Orthopedic Surgeon? And unfortunately, now this is changing. A lot of orthopedic surgeons are really starting to realize the value of regenerative treatments, but many of them still will just, without even a second thought, they say, oh, that's voodoo. Or like, well, if you want to flush your money down the toilet, go ahead. Now, some of them are not necessarily that coarse about it. They'll say, well, there's no evidence that the regenerative treatments, are shown to be beneficial. Okay, many orthopedic surgeons will say that exact phrase. So I implore the folks that are seeing them to ask, well, what have you seen in your literature search? Have you done a search of research studies on regenerative medicine? Because I myself have asked this question of many orthopedic surgeons that tell me, hey, there's no evidence behind that. And I said, well, have you looked? And it's like, well, no, but my understanding is that the research is just not there. They haven't even looked for the research, and they claim that there's no evidence.
Right.
And this happens all the time.
Yeah,
all the time.
Most orthopedic surgeries
Have
do
poor
not
evidence.
have level 1 evidence.
Only
So-
one out of
so-
the top 10
Yeah, so those are
performed
basically
surgeries in orthopedics has level 1 evidence. Only one, and that's carpal tunnel release. Everything else, there's
that's all investigational.
What?
That's
So
interesting.
now we're on the
That's right.
same playing field.
right. It's not even the same playing field. There's actually
It's not
more
even-
level 1
yeah.
evidence for regenerative therapies for
regenerative.
diagnoses in orthopedic surgery.
Yeah.
See, that's why we have Dr. Wang here.
Yeah.
For not just his jokes, but his intellect. It's not artificial.
It's not artificial. He is real deal. Well,
AI right here.
we're gonna put the car back on the road here because we're
All right.
running out of time,
Oh,
and we
shoot.
don't want to miss out on the last two techniques, which are the bone marrow and lipoaspirate. So
Maybe we
maybe
can touch on that.
quickly, if we could touch on that and talk about where that comes into play, why you would recommend that, and then maybe just a quick little guide for patients who have been told they need that.
So there's in a nutshell for joint symptoms, prolotherapy takes care of your mild to moderate symptoms. PRP hangs out around the moderate, and then we get into your adipose and bone marrow for things that are more severe. So arthritis in general is graded 1 to 4. It's not a very sophisticated system, but it's been reliable. And so grade 3, 4 is basically bone on bone, so to speak. So grade 3 is kind of the sweet spot for these tissues that are rich in stem cells, bone marrow, and adipose, which is fat. That's kind of the sweet spot for them. But there's been a lot of evidence that it works on grade 4, and it also works really well on grade 2 as well. So that kind of grade 2 to grade 4 is where we want to use it. So the moderate to severe arthritis, when you have a lot more going on. Sometimes we try PRP and it doesn't work, but more often nowadays we're seeing the patients and we're saying, hey, listen, this is beyond PRP. Your choice is either a joint replacement or a adipose or bone marrow treatment. And in other cases, for say wrist arthritis, thumb arthritis, areas where they don't have a good option, where joint replacement hasn't been developed or isn't well utilized, the only other option is either cortisone injections until there's nothing left, or doing a stem cell rich tissue treatment such as bone marrow or adipose.
Yeah. Again, severity, proximity. Like if someone's coming here from Colorado or
Yep.
LA, which happens a lot, we're not going to do a bunch of PRP. We're going to hit it hard. Also, like you said, severity of the arthritis, but also a tendon or a ligament issue that has a huge defect in it, and there's a hole. So that's where the diagnostic injection under ultrasound comes into play, because I do these on every single patient before I treat. I want to see what that tissue does in response to fluid. So if I inject that tissue and it opens up and I start seeing my fluid injectate swirl around, I'm thinking more I need a tissue. I need a graft. So I'm thinking probably fat.
Yep.
I also have told patients you don't need fat or bone marrow. So not only when do you use it, when do you not use it, right? So let's say we'll pick on knees because that's huge. Someone comes in for their knee pain and their arthritis. Someone calls and says, I've got bone on bone. What can you do for me? I'm not scared. We treat that all the time. But I got to examine them.
Yeah.
So what is their alignment like? Do they have a huge valgus deformity? Are they lacking 20, 30 degrees of extension? Then you got to have a real conversation with these people. Yeah, we can do this stuff, but this is going to be the likely outcome. And are you okay with not having your range of motion back? Because we're not getting that back. Prolotherapy, PRP, bone marrow, BMAC or bone marrow, adipose. These are great procedures, but they're not silver bullets, and they're not a miracle. They don't treat everything. So you got to have a doc who's okay saying this is not for you. You actually do need a replacement, but we got to examine the patient. We got to see what's going on.
Absolutely right.
So one question I had.
Oh, right. Sorry, really quick before you say that, hold that thought. Just to play devil's advocate, there is Dr. Topol in Argentina who did dextrose prolotherapy, a single intra-articular injection for arthritis. It was a great study because they had tissue. They actually did staining and did biopsies.
Correct.
And they have great outcomes. The kicker is they didn't classify their grades of arthritis. So they had level 1 or grade 1 to 4. So you're getting great outcomes with dextrose prolotherapy with a grade 4. So we get thrown for loops all the time. So again, you gotta trust your doc and have a conversation.
Yep. Yeah,
I get surprised all the time.
Right. You can have grade 4 arthritis. And, we've known since the 1970s that you cannot correlate necessarily radiographic evidence of graded arthritis with symptoms. You can have a grade 4 arthritis and have relatively mild symptoms. You can have a grade 1 arthritis and have horrible symptoms, probably because of the soft tissue contributions, right? And so you can have dextrose prolotherapy that can potentially have a positive effect on grade 4 arthritis. I think it's going to be the minority of grade 4 arthritis conditions, but that can happen. Dr. Topol has done some remarkable research. By the way, I just saw him at AOM. He still looks like he's 20 years old, man. I mean, the guy's like...
PRP in the face.
Botox.
Yeah, right? Yeah, right.
No Botox. It better not be Botox.
He's doing PRP.
It better be PRP facial.
But one question I think that is important to discuss is this idea about the difference between true cellular treatments where we're harvesting the appropriately bone marrow and adipose from the individual versus these so-called stem cell treatments, these orthobiologic treatments that, it's like stem cell in a bottle, right? Are they really stem cells? Are they not? Dr. Siddiqui, you lecture on this
Are they
regularly.
viable?
They're
Right, exactly. Yeah.
Are they contaminated?
What can we say about this? Because this is a very important point.
So first things first, in the United States, to be able to use a off-the-shelf product that is a biologic, it needs to be FDA approved as a drug. And to my understanding, there's still no single product out there that is FDA approved to be injected into a joint or your soft tissue. And therefore, it is illegal in the United States. But still, there are many, many practitioners who are doing this. Okay, but so first things first, it's illegal. Second thing is, one of the reasons why it's illegal is this false advertising and marketing that's going on, and it is industry based. And these, like we said, these drug reps are coming to physician offices and touting their injection or whatever they're promoting as a stem cell treatment that's going to fix all their patients. And it's easy to do because you just pop the bottle off, put it in a syringe, and inject it, and you can charge thousands of dollars, often tens of thousands of dollars for these treatments. And so the dollar signs are lighting up in these doctors' heads, and they're doing it. And first things first, these are not stem cell treatments. They had stem cells at one time, but by the time it gets from the donor, which is usually umbilical cord blood during delivery of babies, to the patient, it's going through processing, freezing, thawing, multiple different things. Those cells are all dead. And so by the time it gets you, there are really no stem cells left. There are growth factors, and there are growth hormones in there. Exosomes, so it could be beneficial. And before, when we used this, before the FDA cracked down, we were getting good benefits, similar to more so a PRP.
Yeah, about PRP level.
Not a stem cell. It's not as strong as a bone marrow.
So extremely expensive PRP.
So basically, extremely expensive PRP. Exactly.
Yeah, I was talking with a new graduate recently from residency, got into the regenerative medicine world, and he was a little cocky, and he does the pop the bottle, insert needle, inject in the joint. And he's like, oh, yeah, patients love it. And he told me how much they charge. And I'm like, what? He's like, yeah, they love it. They keep coming back.
That's not a good sign.
And exactly. I was like, why do they keep coming back?
Yeah.
Like it's some kind of cult? Obviously, you're not getting them better. What's going on over there?
Yep, you're giving them some growth factors and anti-inflammatory cytokines, make them feel better for 3 months, maybe a year, and then they're back to square one.
Yep.
Well,
Yeah.
It's something else.
Good stuff.
Yeah,
Yeah.
yeah.
So
Well, this has been very, very good discussion, and I think not only for the medical providers listening, but also for the patients,
Yeah.
because this is information that is not widely known and really needs to be known. So I really appreciate you guys joining us. I think we're running out of time.
Yeah.
We could go on and on and on.
I was just about to say that. You had to cut us
I know,
off
at some point.
because we
Yeah.
can talk about
We have
this for
dinner reservations
hours.
to make.
We have dinner reservations. Right. Sorry, guys. But we really, really enjoy having you here, and we so much enjoy working with all of you. And this was awesome, and I hope that all of our listeners really enjoy this, because I think this is very useful information. I wish we could do this
Agreed.
more often.
Yeah.
Because really, I think a big part of this too is patient education.
Agreed.
And
We can. We
really
should do this more
people need-
often.
Yeah, we need.
Yeah,
to
you're
do
right
more often.
upstairs, you know.
We're here.
I know, you're right.
The reason that we, I'm a humble guy, but I'm going to sound not humble for a second. The reason that we are so good at what we do, we owe a lot of that to Gulfcoast. If I did not have the ultrasound skills that I learned at Gulfcoast, and Dr. Wang, and Dr. Siddiqui, and Dr. Victor Ibrahim, and everyone who came before us, we wouldn't be where we are. So thank you.
Yeah.
Aw,
Yep, I
thank
agree
you
with that 100%.
Yep. Great. Yeah. It's a continuously learning experience, right? You never stop learning. As soon as you think you know it all, you're in trouble.
As soon as you think you know it all, you get a rash of patients coming in back to back to prove you wrong.
Exactly.
All I heard was you get a rash.
You get,
You're gonna have a really bad.
you get like 3 or 4 patients in a row with some weird stuff, and you're like,
I don't know about that.
it'll put some humility back in you.
You got that right.
Well, we call it the practice of medicine for a reason.
We're practicing,
Science and
always practicing. We're never going to get like perfected at it, right?
right. It's not
got that
perfect,
right.
and it's never
So-
going to be perfect.
until AI takes over, right? Just like everything else.
Yeah, right.
Until what?
Until AI takes over everything. Right?
Yeah, AI is going to run the world. No, for real. No, it's always such an experience to sit down with you guys and hear you. And every time I'm in a room with you guys, I'm like, oh, wow, you're so passionate about what you do, and you're such great patient advocates. And I just wish everybody could have a doctor like you guys.
Yeah,
Because
so
I know there's
refreshing.
so many people out there who are just desperate for answers. So, all I say to our listeners is go out there and find a doctor who will have these discussions with you and aren't going to dismiss you and blow you off, and will actually engage in conversation with you and not just tell you that you're crazy, or that this is how we do it, and they don't want to explain why.
Exactly.
They should be willing to sit down and engage with you.
Advocate for yourself.
Better yet,
Educate yourself.
go visit
Just
one
go
of these
visit one
three
of these
guys.
guys.
You know,
We
will.
got
you won't have to worry about it. Because they know what they're doing.
Yes, obviously, come see us. We're amazing. But
There's
But if you're not
humility again.
if you're not near us, just call us, and we might know somebody in your area
Probably
Right.
do.
that we can point you
Prefer.
to.
Right.
Yeah.
Because you do know a lot of people.
We do know a lot of
Right.
people.
Casey's
Absolutely.
got something. Hold
We'd
on.
rather see somebody good than some bobo out
Yep.
there.
Right.
Right.
Yeah, I know a guy.
I know a guy.
Or a gal.
That being said, where can everybody find you guys?
Right.
Yeah.
Yeah. For us, come to our website. I'm sure the same thing for you, Dr. Broussard. Dr. Wang and I work for Regenerative Orthopedics and Sports Medicine, ROSM.org. Look us up. We have a lot of patient information on there.
Yeah, you do.
The educational materials, research articles. We have multiple locations throughout the DMV area, DC, Maryland, Virginia. And but yeah, come to our website, and yeah, feel free to call us up. Well, if you call up and ask, who's good in so and so part of the United States, we'll figure it out for you.
Yeah.
Yeah.
we
You've
did
got a
that.
great Facebook page too.
Yep. And John.
Good.
Yeah. So this is John here, Broussard, Alliance Regen and Rehab. Our website is www.thealliancerx, like a prescription.com. You can visit our website. You can call us. Our phone number is on there. If you are in Florida, we're a great place to stop. Or if you are in driving distance to an airport, we're also a great place to stop.
It's worth it. It's worth it.
No, we love you guys. We just want the best thing for you. You don't have to get treatment with us. Just don't do something stupid.
Yeah.
That's right.
Yeah.
We are very blessed to be able to work with the best of the best. And these guys and all of our faculty that we work with are the top experts. So, we're happy to help you out as well if you can't find somebody in your
Yeah,
area.
you can always come to our website, gcus.com.
Right.
We'll get you hooked up.
We'll get you going.
Excellent.
Yeah.
Great.
Well, as always, it's just a remarkable privilege to have a chance to work with your team.
Aw,
So,
thank you
Yeah.
so much.
yeah, it's always a good time, and your level of expertise continues to amaze me. So thank you so much for the
Thank
opportunity.
you very much. Yep.
Yeah. All right. To our loyal listeners, we really appreciate you guys. We wouldn't be what we are without you. So thank you.
Thanks for listening to the Sonography Lounge. Don't forget, if you like this episode, please subscribe and leave us a review on iTunes, Spotify, or wherever you get your podcasts. You can also find us on Instagram at Sonography Lounge and Twitter at SonographyLNG. If you have any questions, comments, or topic suggestions, feel free to send an email to us at sonographylounge@gmail.com. Have a great week and scan, scan, scan.